Good morning. I'd like to call this informational hearing of the House Health Committee to order. And before we get started, I'd like to have members introduce themselves. If we start over to my left.
Arvind Venkat, Representative 30th Legislative District, Allegheny County.
Jessica Benham, representative from the 36th District in Allegheny County.
Representative Kathy Rapp. I represent the 65th, which is all of Warren County, all of Forest, and a portion of Crawford County.
Dan Frankel, 23rd District, Allegheny County.
Tara Khan, 194th District, Northwest Philly.
Representative Leslie Rossi, and I represent parts of Westmoreland County.
Representative Dave Zimmerman, represent Northeast Lancaster County and Southern Berks.
Tim Bonner, I represent Mercer and Butler counties.
Good morning, Tim Twardzik from Schuylkill County, the 123rd.
Brad Roy, the 6th District, part of Crawford County and part of Erie County.
Rep. Melissa Schusterman, 157th Chester County.
Thank you. And I know we're joined by some members virtually, as well as some of the testifiers. This is an informational hearing around the newborn screening process and a couple of diseases that potentially would be added to it. And I would, before I have some opening remarks, I want to turn it over to my colleague, Chair Rapp, for a few comments.
Thank you, Mr. Chairman. I want to welcome the panelists to this informational meeting regarding newborn screening. Newborn screening is an important tool to detect serious but often treatable genetic and metabolic disorders that may not be apparent in a newborn at birth. Often, diseases that are not identified early can lead to health problems if left untreated. Newborn screening allows for early diagnosis and intervention, which in turn allows for an improvement in health outcomes for newborns. In addition to improved health outcomes, early intervention and treatment can reduce medical costs for newborns as they grow and develop. I look forward to hearing the testifiers today to see what is working, what may need to be addressed, and how the Commonwealth can continue to protect the health and safety of mothers and newborns. Thank you, Mr. Chairman.
Thank you, Chair Rapp. To provide context for this conversation, the House Health Committee currently has two bills that have been assigned to the committee relating to newborn screening. House Bill 1652 would add Gaucher disease to the newborn screening panel, and House Bill 1715 would add Duchenne muscular dystrophy to the newborn screening panel. As we began to look into the complexity of newborn screening, I felt it was appropriate that we start by understanding newborn screening broadly, our current program, and how decisions about newborn screening tests are made now as we consider making changes. Today, we'll hear from individuals who were involved in crafting and are part of administering Pennsylvania's newborn screening program, as well as experts from the advocacy community on particular genetic diseases that could be identified by additions to the screening panel. Our first panel today consists of Lisa Brackbill, a parent whose advocacy helped legislators craft our current program, Dr. Gerald Vockley, a member of the Newborn Screening Technical Advisory Board and former chair of the board, and Secretary of Health, Dr. Deborah Bogan. The order will be Dr. Vockley, Secretary Bogan, and then Ms. Brackbill. If the folks would please come to the front here, we'll begin.
You out of here? Okay.
And I think that Dr. Vockley is in Germany and will be joining us virtually.
Yes, I'm online.
Yep. So, Dr. Vockley, I'll turn it over to you to begin.
Thanks very much. Good morning or afternoon for me, and thanks for the opportunity to bring my perspective on newborn screening to this meeting while I'm traveling here in Germany to a medical meeting. I'm sorry that I couldn't be there in person. As noted, my name is Jerry Vockley. I am the Cleveland Family Endowed Professor in Pediatric Research in the University of Pittsburgh School of Medicine, Professor of Human Genetics in the School of Public Health, Chief of Genetic and Genomic Medicine for the University of Pittsburgh Medical Center, and Director of the Center for Rare Disease Therapy for the UPMC Children's Hospital of Pittsburgh. Newborn screening has been identified by the Centers for Disease Control as one of the top 10 public health efforts of the 20th century. I've had the privilege to serve for many years on the Pennsylvania Newborn Screening Technical Advisory Board, the TAB, as I'll refer to it. This is the group that helps guide newborn screening in Pennsylvania. And as noted, I spent 8 years as its chair. This is a committee that's mandated by state legislation. It establishes newborn screening policy in Pennsylvania. And as its name suggests, it's advisory to the PA Secretary of Health and the newborn screening program on matters pertaining to newborn screening. Excuse me. It helps monitor the program's organization implementation, and it performs metrics and analysis and advises on needed changes to program operation. One of its most important functions is to recommend adding new disorders to the PA panel. I also served on the HRSA Secretary's Advisory Committee for Inherited Diseases in Children and Newborns. This is the group that, until its recent disbandment, developed and guided the federally curated recommended uniform newborn screening panel for babies. This is known as the RUS, the Recommended Newborn Screening Panel, a uniform screening panel. This group is was composed of government health officials, academic newborn screening professionals, and members of patient advocacy groups. As of 2025, this panel includes 38 core conditions and 26 secondary conditions, all of which have been adopted as stipulated by the Pennsylvania Newborn Screening Act to the newborn screening program. Core conditions are those considered essential for newborn screening, while the secondary conditions are those that are detected by screening for the core conditions, and so essentially come along at no extra cost. Not all states are required to implement the RUS, but most do so. And in fact, the specific conditions included in states' newborn screening programs, including Pennsylvania, follow the RUS by legislative mandate. Until its discontinuation, the committee that curated the RUS utilized the utmost scientific rigor with the addition of new disorders when supported by the best available medical evidence. This is really critical that we have something that is scientific rather than political. The loss of the HRSA-sponsored committee provides both opportunities and challenges in the management of the newborn screening program in coming years. The American College of Genetics and Genomics, of which I serve on the board of directors, is working to create a new infrastructure to help coordinate the newborn screening recommended newborn screening panel. But in the meantime, we face the potential to develop a balkanized system for newborn screening that varies on a state-to-state basis. As mentioned, Pennsylvania law provides a mechanism for direct nomination of conditions to be added to the state newborn screening panel, even if it has not been recommended to the RUSP by the committee, the Secretary's Committee, and that system is still in place. It allows for review by our state tab, and then the recommendations can be provided to the Secretary of Health for addition. There's a nomination process. It starts with a submission of a form by a PA constituent, review of the medical literature on the disease with a focus on newborn screening tests and possible outcomes, and then subsequent debate and vote by the TAB on the risks and benefits to all babies about inclusion of the disease in the newborn screening panel. None of these tests are 100%, and so we have to consider the harm brought to families whose babies are falsely identified as having a disease in order to identify babies with true disease. This careful, methodical, and scientific process is the most appropriate mechanism for bringing new conditions to the state newborn screening panel. It also allows for the wise use of public health dollars. I'll give you a quick example. Recently, the Pennsylvania TAB added a new condition to our newborn screening panel known as metachromatic leukodystrophy. This is a devastating disease that leads to neurodegeneration, typically death in infancy. This was brought by a constituent in application, and the Pennsylvania board decided to review it because the federal RUSP group was in flux. The Pennsylvania TAB reviewed the data and decided to add it to our panel. So in short, the system works. There is a way to get diseases on the panel that don't require legislation. I was really gratified that ultimately when the HRSA, Secretary of HRSA ultimately released the report from their committee, that it concluded with ours. I strongly urge the committee to allow the Pennsylvania Newborn Screening Technical Advisory Board to do its good work, serving the babies and families of the Commonwealth while ensuring a medically sound and economically robust newborn screening program. Of note, these recommendations are congruent with a recent report on newborn screening by the National Institute of Medicine and the introduction for the reauthorization of the Newborn Screening Saves Lives Act into the U.S. Congress. I also urge the legislature to continue to provide the funding necessary to bring this critical service to its constituents. Adding new diseases to the panel costs more money, and the program needs support for that. I thank you for your attention, and I'm happy to take questions if there are any before I run back to my meeting.
Dr. Vockley, are you able to stay for and have questions at the end of the testimony, or are you in?
No, I can stay.
Okay, all right. So then we'll
thank you.
We'll proceed and hold questions for all three till after all three members testifiers testify. Dr. Bogan.
Oh, sorry. Now I am. Now you can hear me? Sorry about that. So as you're all aware, I am a pediatrician, and I've cared for newborns for many years as a pediatrician. And the Pennsylvania Newborn Child Screening and Follow-up Program is really an essential program. It was established in 1965, and it has evolved over the past 6 decades to keep pace with scientific discovery and innovation. And it has the same goal as when it started, which is to eliminate or reduce newborn mortality and morbidity by screening for disorders for which there is an effective test and treatment that improves outcomes. The current program has 3 components. The first component is blood spot testing that screens for over 40 conditions, including things like congenital adrenal hyperplasia, congenital hypothyroidism, sickle cell disease, phenylketonuria, galactosemia, just to name a few. Second part of the program is it screens for critical congenital heart defects, and the third is screening for newborn hearing loss. Pennsylvania's program successfully screens over 95% of all the newborns born in the state of Pennsylvania for all 3 components. The Newborn Screening and Follow-up Technical Advisory Board, which is what Dr. Vockley calls the TAB, is tasked with providing recommendations and guidance to the Department of Health regarding newborn screening, and works closely with the laboratories to ensure that screenings are accurate and are performed using current medical standards. That board approval is required by law for adding new screening tests to the panel. As also required by the Act, the board has 15 members, including pediatric physicians and geneticists who are experts in various fields of newborn health. The board meets 3 times per year to discuss new topics relevant to Pennsylvania's screening program, analyzes new scientific data, and reviews screening applications presented to the board for consideration. Act 133 of 2020 requires the department to add all tests that are recommended for inclusion on the Recommended Uniform Screening Panel, or the RUSP, to Pennsylvania's newborn screening panel within 2 years. Screening tests are added to the RUSP by the Federal Advisory Committee on Heritable Diseases in the Newborn and Children. But Pennsylvania also has a path for new conditions to be added to the newborn screening that are not on the RUSP. And as Dr. Rockley just said, for example, beginning in January of 2026, Pennsylvania will be screening for metachromatic leukodystrophy. That condition is not currently on the RUSP, was reviewed by the advisory board and submitted for public comment and approved for addition. And Pennsylvania will be the second state to begin universally screening for that condition. New York was the first just last month. I just want to highlight some of the successes of the program. For congenital heart disease, screening reduces early infant deaths by about 33%. And in 2024, 120 infants were diagnosed with congenital heart disease through this program. And in 2024, 189 infants were diagnosed with potential hearing disorders, and 326 infants were diagnosed with potential genetic disorders through this screening program. So because of these important screenings, hundreds of newborns each year across the Commonwealth receive life-altering and saving early identification and treatment to support their healthiest growth and development. Although the benefits of newborn screening are absolutely clear, newborn screening programs face a wide variety of ethical dilemmas and resource challenges. First, genetic testing has and will continue to evolve, opening the opportunity to identify more and more diseases in the newborn period with blood spot testing. For example, some have argued that newborn screen should have whole genome sequencing, which can identify thousands of diseases. Some of these diseases will not present for decades, for example, Huntington's disease. For others, there's an increased risk, so it'll identify an increased risk, but not an absolute certainty that that will occur in that person, like breast cancer, for example. And there's concern that identifying diseases that will not present for beyond the immediate newborn period creates distress for parents and violates the future adult's privacy. Others feel that all diseases should be identified as early as possible. In addition, there's the issue of limited resources, including healthcare resources and financial resources. Infants identified with a newborn condition from the screening program are referred to the pediatric specialists for further testing, evaluation, and treatment. Unfortunately, there is a huge shortage of pediatric subspecialists even before greatly expanding the need. That whole genome sequencing, for example, would create a huge need. When Pennsylvania remains a state with lower cost to hospital or midwives for screening, there is a cost to testing. Currently, the cost of Pennsylvania newborn screening is shared between the state and the healthcare organization, with each paying approximately half of the cost of the screening panel. The cost per infant is approximately $57 paid by healthcare providers and $57 paid by the state. Each edition of a newborn screen test increases the cost by about $6 to $8, depending on the test. So again, we have limited resources for that testing. So I'm sure I could go on for a long time, but I appreciate the opportunity to highlight this extremely beneficial program offered by the Department of Health to ensure health and safety of our most vulnerable. And I'd be happy to answer questions when the testimony's done. Thank you.
Ms. Brackbill.
Good morning, and thank you so much for the honor of participating in this important discussion. My name is Lisa Brackbill. I live in Hershey, Pennsylvania, and I am the parent advocate who made Act 133 of 2020 a reality. But before I begin, I also want to acknowledge that we are all on the same team. Everybody in this room wants more babies to be diagnosed earlier. We just have different approaches to it. To understand the importance of what we achieved with Act 133 of 2020, I believe it's essential to understand the systemic issues that existed in Pennsylvania and what led me to pursue change. But first, like so many in this space, when I became a parent, I never imagined that I would be speaking to you today about something called newborn screening. But on February 13th, 2015, my life changed forever. My 6-month-old daughter, Victoria, was diagnosed symptomatically with Krabbe disease, a terminal genetic disorder. After a 6-week diagnostic odyssey, we were told 3 devastating things. 1, our 6-month-old was dying. There was nothing we could do, but even worse, we were told if we had caught it at birth, we could have treated it. Those words became the catalyst for my advocacy over the last decade. My mission that day became clear: to ensure that no other family would endure the same fate, regardless of condition. Victoria passed away in March of 2016 at just 20 months of age. Through research and conversations over the past 10 years in this space, I have become a state-level expert on the process of newborn screening condition addition. My work has focused specifically on building relationships with state newborn screening leaders in order to understand and navigate the operational dynamics of state programs, to build relationships, not barriers. My advocacy is rooted in direct collaboration, and that has been evidenced here in Pennsylvania as well. I have established working relationships with over half of all state newborn screening programs, connections that are reinforced when states seek me out for information, which still surprises me. My experience has consistently shown that advisory boards are partners, not adversaries, in effective newborn screening condition implementation. 3 weeks after my daughter died, I attended my first newborn screening advisory board meeting here in Pennsylvania to listen and learn. Over the next year, through research and conversations, I uncovered the flaws in Pennsylvania's system. While Act 148 of 2014 had attempted to add 6 conditions, including Krabbe disease, it was never implemented because it did not address the system's operational or funding needs. It was a perfect example of a legislative mandate that failed because it didn't fix the core issues or provide necessary resources. What I learned was that our system was fundamentally broken and unable to adapt to the times. The 3 barriers that we faced were that the advisory board, which, as you heard, is composed of scientific and clinical experts, lacked the authority to add new conditions. This forced critical medical decisions into the legislative arena. We also faced an inequity issue here in Pennsylvania because not all hospitals were screening for all conditions on Pennsylvania's supplemental panel. This meant that where you were born literally determined life or death if you were born with one of these conditions. There was one particular meeting where Dr. Vockley, after being told that the legislature had refused a budget increase, that's no shade to you, the legislature had refused a budget increase to add a particular condition, and he kind of sighed and he said, "Why are we even here? Why are we volunteering our time, our expertise, and our passion only to be denied in the budget process?" And it was that statement that caused me to pivot my entire approach. I realized that my role was far greater than adding a single disease. I needed to be part of improving the entire process to pave the way for all future conditions. So it became about filling the potholes in the road to evidence-based change. It took me 5 years working with Pennsylvania stakeholders, the newborn screening program, the hospital association, the insurance federation, medical experts, and fellow advocates to address these systemic failures. After 2 initial legislative attempts that failed, we succeeded in November of 2020. In just 65 days, the bill went from committee to the governor's desk, and my husband and I both cried tears of joy and relief as we watched the vote on television, because this is our daughter's legacy. The final bill was stronger than what we started with because it was informed by that comprehensive collaborative effort over the course of 5 years. So this is what Act 133 did. It empowered the advisory board and the Department of Health to add new conditions based on scientific and clinical evidence, removing the need for legislative mandate. It ensured that all conditions on the screening panel became mandatory, eliminating the death by zip code inequity. But most importantly, we were able to shift the majority of the funding, well, as you said, now it's about half of the funding to insurance, while maintaining stable funding through the budget for the newborn screening program. This allows the program the flexibility to grow as science progresses without constant budget request battles. Act 133 went into effect 2,292 days after my daughter's diagnosis. This was not a quick journey, but the work along the way is what has made our newborn screening program truly the strongest in the country. We are the only state screening for everything on the RUSP. We are going to be, as you said, the second state screening for MLD. We are truly a leader in newborn screening. But what I've learned is that quick progress doesn't always mean effective or ethical progress. It is tempting in advocacy to adopt the philosophy that the ends justify the means, that saving a child's life today is worth setting aside evidence-based processes. But our 5-year effort demonstrated the opposite. We were successful because we refused to adopt shortcuts. We focused on building a durable ethical process based on collaboration and science. When the legislature passed Act 133, they affirmed that our public health decisions must be supported by the experts and the evidence, ensuring the long-term integrity of newborn screening for all conditions. Though some might argue that the established process is failing them because it has not yet yielded the result they desire, I consider this to be like a lawyer presenting to a jury. It is up to the advocates to convince the advisory board with the appropriate evidence and medical data in order to persuade the advisory board to vote the way that they desire. When the advisory board says no, it's not a no forever. It's not a failure of the system. It's actually a successful application of scientific rigor, and they can always come back and try again with the evidentiary gaps filled. We fought for Act 133 precisely to ensure that medical decisions are made by experts. These experts must serve as the gatekeepers, ensuring that the ethical standards of newborn screening are upheld. To step in now and mandate a condition be added would actually be to invalidate the very authority you yourselves as a legislature delegated to the Department of Health and the 5 years of collaborative effort that created this robust system. Act 133 is working. We did the hard work to establish a system that prioritizes the best possible evidence-based medical outcomes for every child born in the Commonwealth, and we urge you to uphold that precedent. Thank you.
Thank you, Ms. Brackbill, and so sorry for your loss. Before I turn it over to other members, and direct this to Dr. Vockley, but others on the panel can respond. Can you explain the critical criteria sheet and what is taken into consideration when deciding what is on the panel?
Sorry about that. I just muted my microphone. Yes, I'm happy to review that. This will be a quick once over, but there are a number of really time-honored criteria for addition to a newborn screening program that go all the way back to the early 60s as the whole program was being established. First of all, you have to be able to identify the disease in a way that is sensitive, specific, and that allows you to identify the maximum number of babies and not too many other babies who don't actually have it. So in other words, you want a lot of true positives and not a lot of false positives. You also don't want a lot of false negatives. You don't want babies that slip through the screen because it's not a good one. There has to be a treatment in its original approach. We've slipped out a little bit to acknowledge that sometimes knowing that your child has something is enough reason to want to make that diagnosis, even if you can't treat it. But in reality, with healthcare dollars being limited, we want to be able to treat the condition. It has to be a condition that manifests in the newborn period, or at least in the typical cutoff is the first year of life. As Dr. Bogan mentioned, you don't want to be doing things that identifying things that show up in adulthood. So all of these things. Oh, and then we all hate to talk about money, but the cost-benefit ratio is considered here. How much do you save the healthcare system by identifying a child sooner rather than later? I can give you a real quick example. PKU, phenylketonuria, which was the very first disease ever added to newborn screening in Pennsylvania and nationwide, was a devastating disease. These children have an inability to break down phenylalanine, one of the amino acids that are the building blocks of protein. This is a toxic compound to the brain, and the individuals who had this disease essentially had no neurodevelopment. They were completely non-functional, but yet they lived. And so we still have individuals in our long-term healthcare facilities who are now in their 60s who were not screened by newborn screening and had PKU. What's the cost of identifying one baby, or what is the impact in the system of identifying one baby with PKU? Well, 20 years ago, we used to say that was $1 million. You saved $1 million for every baby identified. Now with inflation, that's probably closer to 10. But you get the idea. It's a big impact on the system to do this right and have the right disorders added to the panel. So all of that information comes to, it used to come to the federal committee. We have that pathway that brings it to the Pennsylvania committee that lets us look at all of those components and identify whether or not a particular condition is ready to go on the RUS.
Chair Rep, I have other members, but
I have questions. Thank you, Mr. Chairman, for Secretary Bogan. And thank all of you for your testimony. Sorry for your loss, but congratulations on all of your advocacy that has made a difference in the lives of newborn babies. So I appreciate that advocacy and your steadfastness in helping make those changes. So, Dr. Bogan, I'm going to be asking you about the Gaucher, I apologize, the Gaucher bill that we have, which I will be supporting if the chairman brings it up for a vote, hoping that my members would be supporting that as well. But from the Community Alliance, it was asserted that there was a meeting held on March 28th of 2024 with no notes or attendance taken, and that Department of Health issued a denial letter in June of 2024 to add the Gaucher disease to the newborn screening requirements by stating that there was no treatment available, even though the FDA approved treatment in '94. And then a second denial for lack of treatment from DOH was sent in March of 2025. I know these are serious statements, allegations. I wanted to give you a chance here to respond, and then see if we have any follow-up questions of other panelists.
Thank you, Rep. I don't sit on the committee, so I wasn't in those committee meetings. But again, we do convene per the requirements of the advisory board. We convene experts in the field. There's a process where you submit the application. As Lisa explained, you submit an application, you provide the evidence for why you think this should be added, and the committee, and we have subcommittees and we bring experts from outside the department advisory board as well to review those and make recommendations. So I can't speak to those deliberations because I wasn't there, but I can say that a panel of experts reviewed the request and made that decision. So again, there is a process that we are that works, right? We are adding diseases and conditions. I think Dr. Vockley, who's a genetics expert, can probably respond a little bit better to some of these questions about Gaucher specifically.
Doctor, if you'd like to respond, I'd be more than happy to listen to your answers.
Surely. So I think that it's an overstatement to say that we've had treatment for Gaucher disease since 1994. We have had a treatment. For the most part, that treatment is effective when implemented at the time of diagnosis, and diagnosis doesn't have to be in the newborn period. Now there are occasional versions of the disease that are serious enough to show up in the first few years of life and are often delayed, no question about that. There also are, there's a form of the disease that affects the brain rather than the rest of the body, which is what the usual form of Gaucher disease affects. And that version of the disease is not responsive to that therapy. So it hits some of the requirements for getting on the newborn screening panel, but it wasn't felt to hit all of them. I will say that I wasn't part of that the original discussion, although of course I voted on the full panel. I was a little surprised when I heard that it wasn't open, because it was my understanding that all of our deliberations are open. Most of our subcommittee meetings, we have parent advocates and other interested people on the call. Our full board committee our board meetings are open. So I'm not exactly sure what happened that time, and if that's a process problem, we certainly ought to fix it, and then bring that disorder back for another review. There also has been some additional information published in the last year or so that might make a difference. But I would I really don't think, as I said in my original testimony, that going the legislative route is the right way to go, and that's because it's just too easy for people to put a use case together that looks very, very compelling, even if it doesn't meet all of the requirements. And I think we should just let the board function the way Pennsylvania law says it should.
Thank you, Mr. Chairman.
Thanks. I have Representative Venkat, Representative Rossi, and Representative Benham. Representative Venkat.
Thank you, Chair Frankel, and thank you to the testifiers. My question is for Dr. Vockley, and in full disclosure, my wife is a colleague of Dr. Vockley's at Children's Hospital of Pittsburgh. I'm a physician and a former director of clinical ethics in the health system where I practice. My question, again, goes to the specific issue of Gaucher disease. Reading the testimony from the advocates who are here today, there was very compelling written testimony from a professor at the University of Pennsylvania, and I'm surely butchering the name, Fikagolu, who is an expert in this area, and I apologize that I butchered the name, indicating that, in his opinion, Gaucher disease meets the criteria in terms of medical intervention for having an improved outcome for individuals who are identified early, as well as the ethical and financial components that go into newborn screening. I'm curious, Dr. Vockley, as a member of the TAB, whether you reviewed that testimony and whether you feel at this point, and you've alluded to this in your response to Chair Rapp, that should Gaucher disease come back to the TAB, given recent developments, whether it would have a different outcome than what it has had in the past.
I think there's a very good chance it would. I have read it, and I've actually made arrangements to speak to one of those advocates when I get back to Pittsburgh, because if we either made a mistake or things have changed enough to push it into the category of we really are there to a point where we can add it to our panel, then I want to help make that happen. Like I say, I think we have a process that works. I know that Dr. Fasulu has joined, so you might want to ask him to comment on the strength of the application. But if that is indeed the case, then I would absolutely support it in the TAB. What I don't support is doing it legislatively.
Okay, and I appreciate that. And then the other question I have is, again, related to the other bill before our Committee on Duchenne Muscular Dystrophy. I do not know if there's been an application to the TAB on Duchenne Muscular Dystrophy. My reading is that the circumstances related to therapeutic interventions is very different than with Gaucher disease. Can you comment on your perspective, given your expertise, on putting aside the issue of whether we should legislatively be involved, the issue of, is Duchenne muscular dystrophy in a separate category from Gaucher disease, given the medical evidence where we are today?
Yeah, I still think that Duchenne muscular dystrophy is not yet ready for two reasons. Number one is that the screening test for that particular condition identifies way too many healthy babies for it to be considered a viable test. There's a very high false positive rate, which leads to a lot of families being called for nothing, and a lot of state funds being used to sort that out with the real for the real disease. The other problem, as you alluded to, is on the other end of it. Our therapies still are not very good. There are some gene therapy approaches that have been developed. They work for a minority of patients, with a small minority of patients with DMD, and in fact, one of them was just pulled off the market because a child with DMD who got that gene therapy died as a result of complications of it. So I will continue to say I'm always happy to review new information. I readily admit that with the 10,000 rare diseases, I may not be absolutely up to date on every last one of those. And if someone brings a package that is compelling, I'm a very strong advocate for newborn screening. I want to see diseases on the panel that do what the newborn screening should do. So I would be happy to take a look at it again. I think right now it lags far behind my understanding as to where Gaucher is.
Secretary Bogan wanted to respond as well.
I do. Thank you. Two comments. One is we have had an application to the subcommittee to be reviewed on Duchenne's muscular dystrophy. So that meeting is being set up currently. So we will be having a committee meeting. And then Lisa reminded me, the process of setting up this committee and reviewing conditions really came out of the act that passed in 2020. And Gaucher's was the first application that came to the committee to review. And so the process has been, we've been trying to bring more transparency to the process of how that committee works. We've posted online the forms we now use, the application process, but we continue to work on transparency and making sure that the committee information is up and available, again, if appropriately, if it's required, that things are sunshined, et cetera. So we are learning, and we continue to make process improvement at the department in that committee process. So again, if Gaucher's should be reconsidered, they should resubmit the application, and we will schedule a meeting as we have done with the other ones.
What's the timing in terms of an application and getting to a decision?
I think part of it is these are volunteers who serve on these committees, and so getting them together to a committee meeting, for instance, Dr. Vockley and his colleagues travel. Many of them are academics, so we send out doodle polls and try to schedule them as quickly as possible. We give the committee time to review the materials as well, but we schedule them as quickly as we can based on availability of the committee members and the subcommittee. And sometimes for the subcommittees, they bring in an expert. So for instance, if it's a condition for which nobody on the committee says we are the absolute, expert, we will bring in experts as well. But we have bioethicists, and the committee is a diverse, well-informed experts like Dr. Vockley that participate, but they all volunteer their time.
Go ahead, Chair.
I was going to ask a similar question. Thank you, Mr. Chairman. So could we expect something from you, say, within 6 months, 3 months? And could you notify us in writing, since we do have legislation pending? I mean, if the committee decides that you're going to put it on the list, obviously we don't need the legislation, but I would kind of like it if you could narrow down the timeline for us.
Let me talk to the committee, the folks at the program who organize the meetings, and get a timeline back to you after the committee hearing. And we're in touch with Erica on a regular basis, so we'd be happy to get a timeline to Erica as quickly as possible.
Okay, and I'm sure, Mr. Chairman, that Erica will be conversing with Mike to
For sure, we
give us the information.
We
Thank you.
Very collaborative staff.
Dan knows Mike too. Sorry, Mike. We'll send it to both of you.
Thank you, Mr. Chairman.
Representative Ventietta, do you have to follow up? Before?
Yeah, no, I'll just leave a commentary for the committee, is that I appreciate the need to be appropriately compliant with the process that we've laid out in legislation, but I also appreciate the frustration of advocates, especially related to Gaucher disease, that the process may not have kept up with further evidence in this. And so I would urge the TAB and the Department of Health to be far more expeditious, certainly looking at Gaucher disease, either in a repeat application or in an application that is already there, to move forward. Because I do think that from listening to this testimony, the circumstances have changed from previous decisions, and that Gaucher disease may be appropriate for the newborn screen at this point.
Yep. Okay.
I just wanted to add about the process because, to be honest, I'm the reason that we actually have the process we have now too, because I am so involved with what other states are doing. And so it was last summer that I came to the board and I said, you know, look at Minnesota, look at Indiana, look at their nomination process, and look at the workflow they give advocates, because I have been active in Krabbe disease advocacy for 10 years, and I have been through this. I've been through when a state says no, and we have to figure out, like, what do we come back with? And so the process here is, it is based on what other states are doing, and I will also note that 48 states do have advisory boards with varying levels of authority, but in no state is legislative mandate actually necessary. There are mechanisms within each state, and I do believe that ours, especially because of the Department of Health's willingness to continue to adapt it and learn, and like Secretary Bogan said, Gaucher was the first one to go through. I'm not on the board, but from conversations I heard, they learned a lot through that. So yes, if like I said, it's like an appeal process in a lawsuit, I suppose. Like they can appeal, they can provide the new evidence. Like I know there were at least 3 journal articles published just this year, like within the last few months, about Gaucher newborn screening. So now would be the time to come back with that evidence.
Thank you. My colleague, Representative Rapp, has a piece of legislation being considered in another committee, so she will unfortunately be leaving. And I guess Representative Rossi is going to fill in as the chair. You can come up here.
Oh, sorry, you okay? I'm sorry. Okay.
Jeez. Sorry. And I think Representative Rossi had a question or comment?
Yes. 1 second. Stay there. Thank you, Mr. Chairman. Dr. Brogan, you mentioned that congenital heart disease is already tested. Is that just a simple EKG?
No, it's not. It's either it's done through looking at both blood pressures and pulse oximetry.
So the pulse
oximetry, which measures oxygenation in the blood and blood pressure. That
seems like a really common disease that, you know, just like Lisa, I had a child that passed away after birth from congenital heart disease, and they didn't catch it, and you know, you go home and you don't know. So I really, you know, have a lot of sympathy for you. I know what you went through. It's very, very difficult. So what I'm being told is, you know, they do these tests for studies, but it's the results, you know, aren't always shared with the parent because it's, you know, they'll do blood tests for studies. Are you aware of anything like that?
So the way the newborn screening works is parents are informed that their child's going to have a newborn screen. At least this is, you know, I did this in a newborn nursery for 25 years. Parents are told they can opt out, but they have to sign something if they opt out for the newborn screen. The newborn screening results, it depends on the blood spot test, but the hearing test is usually done. It's done during the hospitalization, as is the heart test. So the parents are informed, and actually it's often done in the room with the parents for those tests. So they should be given those results right away. And the blood test is mailed to a lab to be done, and the parents receive notification if there's an abnormality. So there shouldn't be parents who are not informed of the results of their child's testing. I'm not aware of.
Do you know, is there a long list of the newborn screening? I had 8 kids, but it's been a while. So I don't know what those current standards are or what they test for.
Yeah, they test for about 40 conditions by the blood spot testing. It's available on our website. I'm happy to send you the list of them. You know, we have a contract with a lab that does the analysis. So again, it's uniform. All the kids are tested for the same thing. And so yes, I get results as a pediatrician. The results also come to the ordering physician. So when I was the doctor in the newborn nursery and the test went in my name because I was the physician seeing the baby, the results, if they were abnormal, came to me as well. And if they were an emergency, they were called to me as well as sent to me via the electronic health record so that I can respond quickly. So, you know, I've called many, many parents with abnormal newborn screen results and tried to reach them. Even once I sent out the police because I had an emergency newborn screen result that I needed to reach the parent and I couldn't get a hold of them. So first I sent a nurse who put a sign on the door and then, yes, that's how the system works. And then we have relationships with specialty facilities that respond depending on the condition, whether it's a endocrine condition, genetics is always informed, and it's kind of divided by the state and who gets informed. So those folks also made aware of the results. But parents are definitely informed of the results. We can't
Thank you for all that information. But I guess what I'm asking that a parent brought to my attention that came in my office yesterday, she indicated that there are studies being done where things like Gaucher are being tested for, but they aren't being informed. It's more of a study. Are you aware of anything like that? Because I just want to know if that's factual or if that's not really
Not that I'm aware of in Pennsylvania.
Not in Pennsylvania. Okay. And since Act 133 was enacted in 2020, how many diseases would you say have been requested by the department versus the legislative side?
You want to answer that, Lisa? Lisa's well up on all of the.
We have had 0 added by legislative mandate, and since then we added Krabbe disease, GAMT, MPS 2, and now we will be adding MLD. So as far as I know, we've added 4 conditions since Act 133. There could be more, but we also actually screen for about 63, but it just depends on how the state counts them, which is different state to state.
Okay, and so for each additional thing, is it an additional $5, $6, $7, $8, or is it just?
It varies, and it does take about, we've added these conditions within about 6 months. That is the quickest that we can get all of the hospitals to sign off on all of the paperwork and their contracts with the lab, but also to get the follow-up program, you know, up to speed and ready to handle another condition.
And some of those were added because they were on the RUSP, right?
Yes.
And some of them were added specifically because of the committee review.
Okay. Were you asking about the dollar amount? The dollar amount, like if it's per, she said
yes,
they added
it's per
4.
test. So for instance, and some tests cost more than others, depends on the type of test that's being done. But it ranges from like $6.50 to $8.50 per child per test. So, and you have to multiply that by the number of children screened in the state, which is about 125,000 a year.
Okay, thank you very much.
Representative Benham.
Thank you, Chair. So for context, I'm a bioethicist by training, and I also have a rare genetic disorder, Ehlers-Danlos syndrome. So a lot of sympathy for folks who are going through genetic testing. It would have saved me a whole lot of hassle and pain if my EDS had been identified much earlier in my life. So my question is primarily, I think, for the docs on the panel, though, Lisa, you're also more than welcome to chime in. When we're considering adding new conditions to newborn screening, how do we weigh the potential benefits of early detection against possible risks of unnecessary medical intervention, family anxiety? Is there ever any harm in testing for more illnesses? I think, obviously, we want parents to have as much information as possible about their child's health. How do we balance these considerations?
Jerry, do you want to go first on that one?
Sure, I'll take a stab at it. It's absolutely a moving scale. So a lot depends on when the disease manifests, how severe it is, if there are benefits to getting it sooner rather than later, even if it's not in the newborn period. I'm actually a very strong advocate of what I call screening for life. You know, let's identify in the newborn period the diseases that are important to know about when you're 1 day old, and then when you're 5, we can do it all over again, and 10 and 20 and 50. That takes money, that takes infrastructure, and so we're not there yet. For something like Ehlers-Danlos, as I'm sure you're aware, the genetic testing isn't even very good for it. It picks up a fraction of what ends up getting diagnosed clinically as Ehlers-Danlos syndrome, and so we don't even have a very good test for something like that. So it's a very complicated question, and I'm sorry if I sound like I'm dodging it, but it's why we look at these so carefully and try to discern if a disease is now ready to be added to the RUSP. There are 10,000 genetic diseases. If we tried to screen for them all as newborns, we would probably have chaos in our medical system. So somewhere between we're not going to do it at all versus we're going to do everything all at birth is the right answer. And we're definitely moving more towards screening for more things. And I think that's as the technology improves, that tendency will continue.
Oh, definitely. And it wouldn't be a discussion around medical ethics if it didn't sound a little bit like you were dodging the answer.
Thank you.
Thanks, Dr. Vockley. I'll just say, we do have 2 bioethicists on the committee specifically to address those conditions. And these are challenging questions. There's no, I think, newborn screen, there have been articles in the New York Times and the Atlantic. These are challenging discussions that we all need to have as a society. And how do you balance, the risks and the benefits? And for parents, establishing the newborn, we know that when parents are faced with things about their children, it makes them anxious as appropriate, right? You have a newborn and you're trying to attach with your baby. And if your baby is well, but you're told that your child has a condition, there's old studies that talk about worried well. The parents that are worried well and they limit their children's activities and they treat them with kid gloves and they're really concerned. So there is that vulnerable child syndrome that you can create in parents as well, out of the love and concern that they have for their child. So I think it is really important, again, and if we have too many false positives on tests, and then the parents spent 6 weeks going through a testing period and it turns out their child's well, and we worried them unnecessarily. That's why you have to make sure your tests are not have a lot of false positives, not many false negatives either, because then you reassure people. So this is a tricky business, and it requires an army of people to really think through this. So, which is why I'm thrilled that we have the volunteers we have for our committee who do that really tough work and volunteer their time to do it because they're passionate. So, I don't know if Lisa wants to add anything to that.
Thank you.
Just that I've sat in 10 years of these ethics discussions and I still feel the same way you do.
Thanks, Representative. Now, I'm going to turn over to our final questioner before we get to the next panel because we are under some time constraints. So, Representative Zimmerman.
Thank you, Mr. Chair. So in my area, there's a family that had a son with a rare genetic disease and ended up with a liver transplant, saved his life, and his liver was able to be donated to somebody else that didn't have that disease. And so, in a sense, it saved 2 lives. So So there's some really interesting work being done and some good research taking place. I'd like to just hear a little bit about the cost factor. It was mentioned a little bit, but if the General Assembly adds a rare or disease to the screening process, what does that end up actually costing, and is it all borne by the department? What does that look like?
So the department, there is a line item in the for our newborn screening program, but I'd have to get back to you on what that change has been over the last couple of years. But generally, when new tests are added, the burden actually falls to the hospitals to pick it up as part of their fee. And don't forget, we have midwives that are delivering babies, particularly in the plain community, where the plain community is paying for that out of pocket. And so each new test does add a burden mostly to the hospitals and midwife centers and midwives that are delivering babies.
Okay, so there's not really an extra cost to the department as such? Or?
Well, it depends on how much money we're given through appropriations.
Sure, I understand.
Yeah.
Okay, thank you.
Thank you. I want to thank this panel. It's been very helpful. Thank you for your contribution. And I'm going to turn it over to our second panel this morning. It consists of Aviva Rosenberg and Amy Atkins. Ms. Rosenberg is the co-founder and co-president of the Gaucher Community Alliance. Ms. Atkins is the director of patient access at the Little Hercules Foundation. While only Ms. Rosenberg and Ms. Atkins are giving verbal testimony, we do have, as noted earlier, Dr. Figiolu, I hope I pronounced that right, an expert in Gaucher who would be available to answer questions about Gaucher and provide follow-up expertise related to questions about treatment manners. So I will let, we're joined by Aviva Rosenberg virtually, and I'll turn it over to her.
Good morning. Thank you for having me. My name is Aviva Rosenberg. I'm from Pittsburgh, Pennsylvania. I am a type 1 Gaucher patient, and I also have a teenage son, Eli. He has type 1 Gaucher disease as well. Professionally, I'm a healthcare attorney. I practiced law for over 20 years, most recently in-house counsel for Allegheny Health Network. I founded this organization 6 years ago to advocate for the Gaucher community across the United States, and it's been a privilege and honor to do this work. And so there's only really a couple things. I have a slide deck, but there's really just one slide that I'd like to share, if it's okay. And I will pull it up right now. Is this visible?
Yes. Yes.
Okay. So I really agree with what Dr. Bogan and Lisa have been talking about the nomination process. In fact, the states that she mentioned, Wisconsin, Indiana, Georgia, Minnesota, our organization has submitted nominations to those states. We've had hearings. We've been approved in 2 of those states, open hearings. There's been attendance taken. There's been, people can come, people can talk. We've had our experts present their evidence, and 2 of those states have voted yes, and 2 of those states were currently under review. So you are right. There is a process that can work, and we fully support it. The issue that we've had in Pennsylvania is that we have submitted the nomination packet 2 times. So Dr. Bogan suggested submitting the nomination packet the 3rd time. That's fine. I'm happy to submit a nomination packet the 3rd time, but I would like to know, how will it be different? How will it be different if I submit a nomination packet a 3rd time? Because the first 2 times I submitted it, there was no hearing. We never got a hearing. There was a secret meeting. No idea what happened in that meeting. And then we continue to receive letters, even after the 2nd nomination packet was submitted, that there's no treatment. So it's really hard for an advocacy group with very limited resources to continue to go through a process when we have no transparency and no idea what is going on. Our doctors have taken time out of their schedule to write these nominations, to provide evidence, to provide peer-reviewed journals, to draft pages and pages of documentations and case studies and evidence, and submitted these, and these packets were never disseminated to the full committee. So I, again, really support this process. And I would have loved to actually work with the Department of Health to make this happen. But the reason we find ourselves here today is because of what didn't happen, not what did happen. Universally across the country, there is, with doctors that treat Gaucher disease, there is really no disagreement that Gaucher disease is a good condition for newborn screening. So I'm still, I don't know what went on at the secret meeting where it was denied 2 times, but obviously that's not great evidence review medicine if nobody even looked at the packet. So again, I have slides on showing what other states' data has done, and the cost of it. I do want to point out that Pennsylvania already uses the equipment. The state lab has the Neo-LSD kit. And so the baby, there is no additional blood from the baby. The machine is already running the test for Gaucher disease. So all they would have to do is uncover the results. There's no additional cost. The machine, the equipment, the blood spot, everything is there already. And the state is withholding the results that the machine could be programmed to spit out. So in terms of cost, the only additional cost would be for the staff to make the follow-up phone call. And there is a cost for staff, based on other states' data, probably most similar to New Jersey and Illinois. There would be a cost because of the Ashkenazi Jewish community. And the final thing I want to point out is that this disease is the most common disorder in the Ashkenazi Jewish community. So while MLD, the only other condition that has passed the committee, was able to approve, this disease was held up. And so I don't know, I'm not sure what's going on and why we were never given a hearing. But I did want to point out that this is most prevalent in the Ashkenazi Jewish community. And so we have 2 big centers of Ashkenazi Jews in Philadelphia and in Pittsburgh. And so we know that there are children out there that are not diagnosed. And so I want to make sure that everybody understands that this is a different state than perhaps Montana. And so we know there's children out there that are being misdiagnosed, that are growing up with pain when there's good treatments available. And I am happy to provide other states' data to any member of the committee who would like to have it. And that's essentially what this slide deck does. And so I just want to, I don't want to take up more of your time, just to emphasize that we tried, we really, really tried to go through the Pennsylvania Department of Health process. And we support Department of Health process. It's worked in many other states for Gaucher disease. But we're sitting here today because this process did not work. And so we are asking you to please bring this up for a vote, and let's give the state of Pennsylvania the same access to medication, to the same access to newborn screening that New Jersey has. And I thank you so much for your time.
Thank you. I'm going to have the other testifier, and then we'll get to questions. Ms. Akins?
Hi, good morning. My name is Amy Akins, and I reside in Glenshaw, Pennsylvania, which is a suburb of Pittsburgh. I have a 21-year-old son named Elijah who lives with Duchenne muscular dystrophy, or DMD, and I'm also a genetic carrier of the disease. Additionally, as mentioned previously, I work for the Little Hercules Foundation, which is a patient advocacy organization focused on access concerns for DMD as well as other rare conditions. I'm here today in support of newborn screening for DMD. Duchenne is a genetic disorder that's characterized by progressive muscle loss. It's multisystemic, and it affects multiple parts of the body, including skeletal, lung, and heart muscles. Many parents of those with Duchenne recall the first time they heard the word Duchenne. This is not surprising, as we know that about 1 in every 3 cases of Duchenne is caused by a new or spontaneous mutation in the affected child with no known family history. I'm unable to recall the first time I heard Duchenne because I don't remember a time when it was not part of my life. My family's lost 4 boys to the disease, 2 uncles who passed before I was born, a cousin who succumbed at age 19, and my brother who passed away at 18 shortly after a bout with pneumonia. As a toddler, I had concerns about Elijah's development compared with his peers. He never crawled, and he didn't walk independently until he was 17 months old. My fears were repeatedly calmed by his pediatrician, who attributed this to him being an only child. And in my work with families, I've learned that this is a common scenario. At age 2, I myself made a parent referral to the Early Intervention Birth to 3 program. They completed their evaluation, and he actually passed the physical test at that point, qualifying only for education services and speech therapy. When he turned 3, he transitioned to the Early Intervention Preschool program. Sometime after being in that program, the PT at the time mentioned that she had some concerns about his muscle tone and his development. Shortly thereafter, at the age of 4, he was diagnosed with DMD. At the time of his diagnosis, there were no approved treatments, only steroids to try and slow progression, which comes with its own set of side effects. Elijah's had the typical progression, I'd say. Between the ages of 5 and 7, getting off the floor became difficult and then impossible without the use of furniture to drag himself upright. Between the ages of 8 and 11, the ability to climb stairs diminished to the point of non-existence. And then at 13, he fractured his femur after a fall. As is common with these type of injuries and DMD, he never walked again and needed a power chair for mobility. Through his teens, he continued to get weaker, and he lost the ability to do most daily living skills independently. He now uses a ventilator at night. Even with a family history, there was a big gap in time from symptom onset to final diagnosis. I know that had it not been for my family history, his diagnosis would have taken even longer. Other parents have described scenarios where they have taken their young child to physical therapists who have implemented strength building exercises. Weight resistance exercises can be very damaging to muscles that don't heal, like Duchenne. Earlier diagnosis not only helps parents and patients reach intervention sooner, but it also prevents these detrimental therapies from being administered by well-meaning professionals before diagnosis in the first place. Currently, there are 8 approved treatments for DMD. Early initiation of treatments may preserve muscle longer. Newborn screening detects these patients early, allowing them to receive their treatment sooner, possibly before any symptoms appear. Additionally, newborn screening helps identify children who could be eligible for clinical trials involving treatments that are in development. And it also identifies carriers, which is extremely important, as there are a subset of female carriers who have significant symptoms. Recently, I learned of a 9-year-old girl who was very symptomatic. It took 7 years for them to obtain a diagnosis. Female carriers who appear asymptomatic, like me, are also at risk for health complications and need cardiac screening as adults. I'm in complete agreement that newborn screening for Duchenne be added to Pennsylvania's newborn screening panel. And as mentioned by others previously today, Act 33 of 2020 provides that mechanism for expanding those conditions without the need for legislation. I supported the formal nomination for Duchenne to be added through Newborn Screening Advisory Board this past spring, and I'm grateful to the committee, which I understand will vote on Duchenne soon. I'm also thankful for Representative Flood's expression of support for DMD newborn screening through House Bill 1715. I'm in support of any method to expeditiously add Duchenne to the newborn screening panel, because the faster we get children diagnosed, the more time we give them with stronger muscles. I appreciate the opportunity to testify about this issue, and I welcome any questions that the committee may have. Thank you.
Thank you so much, Ms. Rosenberg and Ms. Akins. And with that, let me turn it over to Representative Benham.
Thank you, Chair. So my question is about how we support parents through this process. Obviously, diseases like this can have a range of impacts and potential treatments. What supports, and this is for either one of you, do you anticipate that parents would find helpful as they're navigating the uncertainty and the anxiety around all of this process?
Thank you for the question. So when we have a newly diagnosed patient in our community, oftentimes families or parents, and it could be extended families, will reach out to us as a patient advocacy organization for information, for support, and we connect them with other families that have traveled this path before, especially within their area. We also connect them with a list of expert physicians. Because these are rare diseases, it's often helpful to be referred to a center of academic excellence so that they get the very best treatment. And families find it very, very helpful. I know I did, my son did, when we connect with other people that have gone through the same thing that we have gone through. And so, family support is very important. Mental health support is very important. We encourage our community to seek mental health treatment when they receive a diagnosis. And we have very active educational programs. We have national patient conferences, regional meetings. So I think within the rare disease community, we try our very hardest to support new families and to be there with them for every step of the way, with them and their treatment, with their treatment physicians.
Thank you. Ms. Akins, did you have anything to add?
I would second what Aviva has said, but I'd also add in Duchenne, we have multiple organizations that support patients and families dealing with Duchenne. Some of our larger organizations provide a whole plethora of services, including helping people process mentally the genetic results, helping them with standards of care. And also, we have two large organizations that have certified care centers that they have a process, and then the Muscular Dystrophy Association as well.
Thank you both.
Thank you. Representative Rossi?
Thank you. Amy, you went over how this affects your family, but Aviva, could you go in depth a little more of what this disease does to you and your son? What are symptoms? If you didn't have the treatment that you are having right now, what would the effects be? Could you just touch on the disease a little bit and how it affects you, just since it's so rare and many in this room don't even know what it is? I had to say it a couple times to know how to say it. So if you could touch that, that would be helpful. Thank you.
Sure. I can definitely talk about, my personal family, and then I'm going to let Dr. John, talk about, since he treats many, many Gaucher patients of all types, his experience with Gaucher disease. So in terms of me, I'm old. So I grew up in the time when there was no treatment. I was not diagnosed. Even if I was diagnosed, I would not have had treatment. I grew up with very frequent broken bones, avascular necrosis, which is what's called bone death. So I was often, in severe pain. I had, the bone marrow within the bone actually died. I had constant nosebleeds. And anemia, where the doctors, in the 1980s were telling your parents to cook more steak and more eggs and feed the kids, to get them through their anemia. Very low platelets. My platelet count was often below 20,000. So this would mean that if I had any type of accident or trauma, you'd risk bleeding. And that is, so I had no type 1 disease. We have no neurological involvement. My son we were so lucky to have him diagnosed at birth. And so he had none of these symptoms because every single year we knew from birth he was followed by a specialist who monitored his clinical symptoms. And then when he turned 11, we started treatment. So he was so lucky. And this is the same with kids coming from newborn screening states. They are very, very lucky to never exhibit symptoms and to be able to start treatment before that point. So that's just my personal story. But I'd like for Dr. John to share a little bit about Gaucher patients in general and the differences in the disease.
Thanks, Aviva. I think you explained very well. So there are three types of Gaucher disease. 95% of patients have type 1 Gaucher disease, and which Aviva has. And they present with easy bruising, bleeding, hepatosplenomegaly, abdominal pain, abdominal distension, fatigue, and bone disease. Many times, these patients are not diagnosed, and they come to us with severe bone crisis, and it is irreversible damage. At that point, there is not much treatment available to protect the bone disease. So we want to start treatment as early as possible to crisis and bone disease. In the last paper, we described two cases One was diagnosed at 4 years of age when she presented with severe bone crisis, bone fracture, and bone necrosis. And a brother was diagnosed through newborn screening. And that patient who presented with bone crisis and bone fracture actually was sick with anemia, low hemoglobin levels, and thrombocytopenia, low platelets, easy bruising, bleeding for a long time. And that patient was treated by her primary physician at iron deficiency for more than a year. And then one day she presented with severe bone crisis, bone fracture, and they came to the CHOP emergency room one weekend. And of course, the bone is damaged, and that patient, even we start the treatment right away, and that patient will probably have a replacement in her. So there's no way to go back to irreversible damage. And I recently made a diagnosis of a 3-year-old girl last week.
You're breaking up. You're breaking up. Can you adjust the speaker?
Sure. I recently diagnosed a 3-year-old patient from Pennsylvania last week.
Yes.
Can you hear me better? I recently diagnosed a 3-year-old patient last week from Pennsylvania. She was symptomatic at 10 months of age with easy bruising, bleeding, and anemia. And she was seen by 3 different hematologists, and many workup was done. And she also had abdominal pain, and she had endoscopy. She was not really diagnosed with anything, and then everything was coming back negative, but she was getting worse. At CHOP, hematologist sent whole exome sequencing, which showed 2 genetic changes in the Gaucher gene, and she came to us. We confirmed the diagnosis, and this is a huge diagnostic delay and diagnostic odyssey, and the parents were really very upset because all 2 years they were going from one physician to another to get a diagnosis and treatment, and no one was able to make the diagnosis, even in there is no way to make diagnosis of Gaucher disease without newborn screening or family screening. So it is really very important disease, and there are multiple treatments available. There are 3 enzyme replacement therapies. There is an oral therapy called substrate reduction therapy, and many treatments are available. But early diagnosis is the key, so these medications can work better, and these patients can have a normal life.
Thank you. Chair Rep, before we get to, do you have any questions? Okay.
Thank you.
Let me just ask, I mean, I don't know if you have the access to answer this question, but we know that a number of other states have added Gaucher disease. I'm not sure about Duchenne. What have been the impacts in those other states? Do you have any information on that?
A few other states are screening. Aviva, do you know how many states are screening now? I know Illinois, maybe 5, 6.
I'm happy. I mean, I have all the data. So there's currently 8 states that are screening for Gaucher disease. Wisconsin has approved it, but has not started screening yet. And then it's in the nomination process in Georgia and Minnesota. So what the literature is showing about incidence is all showing up in the states. So obviously, like states like Tennessee and New Mexico, they're having a lower incidence rate. So they're showing about 1 in 100,000 live births, which is what's the general population. States like Illinois and New Jersey, it's much higher. Their rates are much higher. Because of their Ashkenazi Jewish population, which the incidence rates are approximately 1 in 750 births. And so, Illinois, New Jersey gets about 19 cases a year of of a confirmed positive, I think, and Illinois is less than that, but they get a few a year. And then the other, Tennessee went years with 0 cases, and the same Oregon went years with 0 cases. So you're talking about very few. This is not going to change the Department of Health work plan. This is not going to cause their staff an excess. You're talking about 15, 20 calls a year.
Thank you. Any other members?
In Duchenne, there's 8 states that have approved.
Okay. Thank you both. I'm going to first of all thank this. Oh, yeah. What in Duchenne? Do you have any information about other states?
Yeah, so in Duchenne, there's 8 states that have approved. Ohio started screening in 2024. Minnesota started screening this year. Massachusetts will begin by June of next year. Arizona will begin up by October of 2027. And then in New York, Illinois, Texas, and Florida, the newborn screening has been approved by legislation, but they're working on funding currently. But I don't have the incidence numbers for identification.
No, thank you. Well, I want to thank this panel for being here today virtually and providing the committee with great information, I think, as we deliberate whether to proceed with legislation. And I want to turn it over to Chair Rapp for her concluding remarks.
Thank you, Mr. Chairman. I apologize again for not being here for the last panel. I had to be elsewhere. But I want to thank all of the panelists for your testimony. We learned a lot today from the testimony and from the handouts, the materials, the charts, and everything that was provided to the committee. I want to thank you for all of your hard work in putting that together and providing it to us. So the law regarding approval of additional newborn screenings was amended in 2020 to update and standardize the newborn screening process in the Commonwealth. As with any law that provides oversight by a board or commission, the General Assembly must determine when they should intervene and when they should defer judgment to the board or commission. Often that decision is made on a case-by-case basis. And often when we have a hearing on an issue, it can also maybe help to move a process a little bit further and a little bit faster. If not, we fall back on legislation. And Mr. Chairman, I'm not speaking for other members of this committee. However, given the information and the materials provided, I'm prepared to vote for House Bill 1652. Should you bring it up for consideration, I would encourage other members of the committee to support this bill as well. But the bill has my full support unless the Department of Health is very forthcoming and would approve this for newborn screening. So thank you, Mr. Chairman, and thank you for all your hard work in putting this committee and the hearing together.
Thanks, Chair Rapp, and I again thank the testifiers today. This has been really, I think, very helpful to shed light on this issue. I think it's informative generally for us to be better informed about the newborn screening process. And I would agree with Chair Rapp that having this legislation pending is, hopefully we'll have a conversation with the Department of Health about expediting this process or taking a look at forcing legislation on these issues. So I look forward to that discussion as we move forward. And I want to thank everyone again today. I don't pretend to be a medical expert, but I do believe our values demand that we think about helping the most vulnerable, thinking and being thoughtful about the deeper questions related to helping children and families live the best life possible. Thank you all for your testimony, and stay tuned. Thank you.